dyslipidemia, obesity, metabolic syndrome, they are the parents, yeah, of cardiovascular disease, cancer, colon cancer, breast cancer, and so on. Yeah? And heart attacks, strokes, diabetes mellitus, all of that. And you can see that this increase in trend for obesity and overweight across the world. Look at the map, and you can see that Saudi Arabia is on that dangerous zone with some of the developed world countries like US and Mexico and stuff. They also have more weight on them, and that's not a good thing actually. And we know this. The reason is eating too many processed food items, fizzy drinks, a lot of sugary drinks and sugary substances, and then also being sedentary, less activity, trying to remain indoors and so on. So yeah, that's a very alarming situation. And some people say the epidemic of obesity. Yeah, but that's true. All right. So what we are doing today are the drugs which help reduce the bad lipids in our body. But before that, we need to understand how the lipids circulate in our body, because this blood lipids, which we test frequently as lipid profile, actually gives us the circulating lipids in our plasma. Major part of it is as a complex of proteins and lipids. So a lipid core surrounded and protected by proteins. Remember, plasma is water-based, is an aqueous solution, isn't it? And lipids don't mix well with water. So proteins coat them and make them easily transportable. So these apolipoproteins have two main functions. Number one, they make it easy for the lipids to get transported through the tissue fluids, plasma and tissue fluids, of course. And the second one is the docking at just different types of receptors, whether it's on liver, it's on adipose tissue, it's on skeletal muscle, or anywhere. So those lipid packets of that consignment has to have an address, and this address is the receptor. And then to bind to that receptor, we need a protein. Yeah. So that's why these apolipoproteins, which cover the lipoprotein molecules, these lipoprotein complexes, their function, this major function is, number one, they make it transportable. They carry them, right? And they act as a suitcases, for the luggage to reach their destination, and then find the address where they should be supplied or delivered. All right, so there are two pathways. One is exogenous, which depends on our meals, our food, whatever we're taking. And the other one is endogenous, which depends mainly on what lipids liver is going to produce. Clear? Okay, good. Now, this intestine pathway, or I would say exogenous pathway, delivers lots and lots of triglycerides, and they are absorbed after digestion. The digestion, there are enzymes starting from the lingual lipase, gastric lipase, and then we have pancreatic lipase in upper part of small intestine. Okay? And of course, this is required because the enzymes are in aqueous solution, so we need bile so that the fat becomes emulsified, and then the enzymes can reach deeper into the solution and for effective digestion. Otherwise, there will be bloating, there will be diarrhea, there will be malabsorption. So these absorbed dietary lipids are actually absorbed into lacteals, which are part of the lymphatic system. Right? Remember, whatever blood is supplied to the tissues through arteries is drained by the veins and lymphatics. Yeah, some fluid would always be left behind, and this is then cleared off by lymphatics. So veins and lymphatics, they help clear whatever comes in, okay, through arteries. The same way, here we have absorption of fats in the lacteals, which are part of the lymphatic system, and ultimately, at the root of the neck, these lymphatics then they find their way into the venous system, so it returns ultimately to the venous system, and this venous system then keeps this throughout the body and circulates it. All right. So ultimately, when the lipids are deposited where they have to be, where in different tissues under the influence of different lipases. For example, hormone-sensitive lipases, one type of lipase. So these lipases, they try to receive on the way they deliver the lipids, and these kind of micro-remnants are then, recalled by the liver back for recycling, and then they produce again, and this, goes on and on and on. So this is the fresh supply of what? Of lipids, especially the fatty acids. We take fried foods, we take all types of processed foods. It is rich in cholesterol as well as in fatty acids. Yeah, fatty acids are delicious to taste, so our tongues have developed that taste. Whatever is more oily, fried, we like it, isn't it?
Yeah, that's good.
Yeah. So that's why we ingest more triglycerides, fats, not fatty acids, not but triglycerides. And of course, the liver. Now, liver has a different function in terms of the lipid metabolism. Liver synthesizes cholesterol. Liver synthesizes cholesterol. Little amount comes from our dietary source of cholesterol. Major part of that cholesterol is actually synthesized in the liver. Okay? So that's why when people say, all right, doctor, we don't want to take statin, I don't want to take another medicine, what about I just, deprive myself of lipids? Okay, fine, you can. That's good actually. But 3/4 of cholesterol will be ignored. Yeah, you are taking care of just 1/4. What about this 3/4? How you would actually control it? So we need to give you some drug for that, because we feel statin is the drug of choice. Yeah, for that. All right. So why this organ synthesizes cholesterol? Because cholesterol is part of our lipid membranes. Number one, we need it actually. We can't live without cholesterol. We need it. Number one. Number two, there are metabolic pathways which depend on fresh supply of cholesterol. For example, we have cholesterol hormones. We have testosterone, we have estrogen, we have progesterone, we have cortisol, we have glucocorticoids, mineralocorticoids, yeah? And we have so many other derivatives which depend on cholesterol. And we have bile salts, which are also derivatives of cholesterol. So without cholesterol, we won't be able to absorb dietary fats. We won't be able to reproduce. We won't be able to survive, because our cortisol will go down, our mineralocorticoid will go down, so we'll lose sodium, we'll lose potassium. We will be, lot of issues. So basically we need it, but we need to optimize it. Okay? اعتدال, yeah, we need to make it تعديل, yeah, it's for تعديل, we need to optimize it, alright? So, liver actually produces these very low density lipoproteins, which are suitcases of different types of lipids, and the suitcase is the protein part, yeah, contains those lipids inside. Why? So we already explained. So VLDL is very low density lipoprotein because it has more yellow. It has more
Fat.
which fat? So yellow is triglyceride, orange is cholesterol, and this blue means proteins. Alright, now you can easily compare what is the relative or proportionate content of a given lipoprotein. Alright, so then VLDL circulates through the body, distributes the fat. Which fat? Both of it, cholesterol as well as triglycerides. And then becomes intermediate density lipoproteins and ultimately low density lipoproteins. Alright, and then LDL will be taken back or recalled by liver, just like these. Okay? So that becomes a loop, you know, coming here. Alright? But just like arterial blood supplies the body, veins take drain it but leave behind something, which is later on cleared by lymphatics, lacteals and lymph, isn't it? Same way, there is a supply of fat, but something will always be left behind. So body does not function on accumulation. What the balance sheet has to be balanced, you know, that's why it's called balance sheet. Whatever comes in, it has, ultimately it has to go somewhere. Alright? So because there will be something distributed and not cleared readily, will take time, there is another parallel system, we call it HDL, also produced by liver. And the job of HDL is to go scavenge, hunt, and take those remaining fat back to liver. How does it take it? Well, HDL is produced, and then it exchanges that lipid and calls LDL, hey, LDL, you have forgotten something. All right, take this away. All right? So this is how HDL functions. It hands over whatever it has collected back to LDL because it's LDL's job to take everything back. Yeah? The cleaning job is of LDL and has to do it efficiently. Otherwise, this is something which will pick it up, does the job, and then hand it over back to the LDL. All right, take it away as well. So, got it? Yes. This is how it is. All right. Now, these lipoproteins have those proteins on the lipoproteins are called apolipoproteins. Yeah. So the major apolipoprotein on HDL is alpha, and on LDL it's beta. Okay. So we always calculate atherogenic risk and all that, you know, and whether the lipid profile is good or bad on the basis of the ratio. So LDL divided by HDL, that's a ratio, LDL HDL ratio. Sometimes you will find in the literature the description of the same ratio as a ratio between the apolipoproteins. So beta alpha ratio. Remember, here is the beta apolipoprotein and here is the alpha. So beta alpha ratio. Beta and alpha apolipoprotein. Because lipids, they keep on changing. I mean, say for example, if you say for the lipid profile, if you fast for 8 hours or 10 hours or 12 hours or 16 hours, the lipid levels may change with that consumed. It's a dynamic process. On the other hand, this apolipoprotein is a relatively stable concentration. right? So that's why it's easier to measure, but it's costly. So that's why most of the time we don't. We just ask the patient, all right, you fast for 8 hours or 10 hours and then come back to the lab and give you a fasting sample. At the same time, we test the fasting blood sugar and the blood glucose as well as the lipids. All right? Okay, got it? Now, the therapeutic intention in dyslipidemias would always be we want the good cholesterol, which is HDL higher. We would like to support the function, all right? And we would like to reduce the LDL, bad cholesterol, which is LDL and VLDL, as much as possible. The ideal ratio is 1:1, but 1:2 is also good. 1:3 is also fine. But 1:4, 1:4, that's not a good idea. 1:5 is, of course, worse than 1:4, and so on.
One HDL and 4.
Yes.
Okay.
Yeah. So 1:4 means 1 part HDL and there are 4 parts of LDL. Yeah. So the ratio will be 4. 4:1 actually. But it's easier to describe it 1:4. Yeah.
Ratio of HDL to both LDL and VLDL or
LDL.
Or only
LDL. VLDL is short-lived, so we don't actually measure, take this in an account. Sometimes we do total cholesterol ratio HDL. That is also doable. Yeah, that takes into account VLDL, LDL, cholesterol esters, and all that.
because
Yes.
all of them they will have cholesterol as
Yeah.
their
So you can do either way. Either LDL HDL ratio, which is long history of establishment and it's established, or total cholesterol over HDL. Okay?
Does it point for the same thing?
Sorry?
Does it point for the same thing?
Yeah, it gives you an idea that which one is good. But sometimes in familial dyslipidemias, you may have normal LDL, but abnormal VLDL. So the total cholesterol will, correct? Yeah. So in that situation, if there is that's why cholesterol HDL ratio is also a useful indicator in that situation. Okay. So what are the drugs to control dyslipidemias? Number 1, statin, and that is the most important for us. You know statin, inshallah you know.
Yes.
Yeah, we tell.
I think
Okay.
this is
So-
a variation.
Sorry?
I think this is a variation in terms of
It's not
slides.
the
It's not the same
slide
slide,
that you
yeah.
have.
No, I uploaded in the morning.
We have
The
the
morning.
updated
Okay, Doctor, you
version.
uploaded.
It's not the same.
Which one uploaded?
Anti-hyperlipid. I
Today,
uploaded.
today.
Yeah, it's
Yeah,
morning.
we have one from yesterday.
No. Welcome. So the drug list is in front of you, statin, which is by far the most important group. Well, by the way, even those slides would also have almost a similar content.
Yeah,
But I think this has been more organized rather than the previous ones. And we emphasize on some clinical aspects more in these slides. All right, so SMT-CoA reductase inhibitor. Statins are SMT-CoA reductase inhibitors. What is SMT? What is SMT, by the way?
A substrate in the cholesterol synthesis.
Yes. So it is hydroxymethyl glutaryl coenzyme A. Okay. Remember, cholesterol starts. The basic building block of cholesterol are the 2 carbon hydrocarbon moieties acetate. So it all starts from the acetate. The 2 carbons, and you add another 2, and then another 2, and another 2, and keep on adding. So acetate, acetoacetyl CoA, and then HMG CoA. So HMG CoA is the third step, and this enzyme treats this HMG CoA in a way it oxidizes and reduces it actually. So it's a reductase. So it reduces it into mevaloic acid. Okay? So mevaloic acid is the product, which is the fourth step. This HMG CoA is the third step. So this is the substrate. And the enzyme is HMG CoA reductase. Okay? Alright. Then we have fibrates, which are actually agonists, stimulants of a nuclear receptor, a nuclear factor, which is PPR alpha. There is PPR alpha, there is PPR beta, there is PPR gamma. PPR gamma is relevant to the drug we use against diabetes, pyrazolidinediol, pioglitazone and that, rosiglitazone, pioglitazone, those drugs. And PPR alpha for fibrates, for the fatty acid synthesis. So PPR alpha agonists
For what, doctor?
for the fatty acid metabolism. Yeah? So PPR alpha is peroxisome proliferator activated receptor alpha. Okay? These are agonists, not antagonists, mind it, alright? Statin is an antagonist. PPR alpha agonist. That's the difference. Alright, then niacin, or it's a derivative of nicotinamide. There are a lot of derivatives of niacin. Look at the nicotinamide. NAD, nicotinamide adenine dinucleotide. Yeah, that's a reducing covalent. And that depends on formation on niacin. So that's why niacin is a vitamin. Yeah, vitamin B3. B complex vitamins, which include B1, B2, B6, B3, B5, B6, and B12. Now these are involved in energy metabolism, especially the intermediate metabolism and biosynthesis of lipids, all right, as well as biosynthesis and metabolism of nucleic acids. So these are, as well as amino acid, the carbon skeleton metabolism of amino acids. So these are very much important in different types of metabolic pathways. Now, B3, niacin, as a vitamin, we sometimes use this to increase HDL more than reducing LDL. Yeah, its action is more pronounced on increasing HDL.
Okay. It's inhibit excretion of VLDL.
Sorry?
Does it inhibit the excretion of VLDL?
It also reduces, but there is more pronounced effect on HDL. So I'll show you some slides at the end and then ask you some questions. Yeah, the way we ask you in the exams. Alright, then we have drugs which act on or actually they help reduce the absorption of actually bile acids are derivatives of cholesterol.
Yeah.
So when you stop the recycling of bile acids,
So more cholesterol is
yeah,
converted to
it's
bile
lost. So the liver will try to supplement the lost amount with new synthesis of bile salts and the diversion of cholesterol synthesis from the cholesterol esters and VLDL to bile acids, because that becomes an emergency. Essential services. Alright, we have other drugs, but they are available in US, not available to the best of my knowledge here in Saudi Arabia and the rest of the world. So we will just briefly talk about them. Maybe in future they will be available, but we are managing dyslipidemias very well with these drugs. And those drugs are actually required in difficult to treat dyslipidemias in very rare situations. Alright, so cholesterol biosynthesis, as I already discussed, acetyl CoA becomes acetoacetyl and then HMG and then mevaloic acid. And you can see the HMG CoA reductase, not synthase, mind it. Yeah, sometimes we can give you similar names, SMG-CoA reductase, SMG-CoA synthase, SMG-CoA oxidase, whatever. Yeah. So it's SMG-CoA reductase. Okay. All right. So statins, they target the SMG-CoA reductase. All right. They inhibit the synthesis of cholesterol because SMG-CoA reductase is the rate limiting step in cholesterol synthesis, biosynthesis of cholesterol. By the way, where does it happen? In which organ? Where?
Liver.
Liver. Okay, good. Yeah. So, yeah, this we actually talked about. That, you know, when you reduce the biosynthesis, what happens? See, when you reduce the biosynthesis of what? Of cholesterol, the liver, because of its metabolic needs of cholesterol, will try to grab as much cholesterol available as possible in circulation back. That means it will increase the number of LDL receptors so that more LDL can be taken back and nothing actually escapes. Yeah? So, because LDL receptors will be upregulated, so initially there is a synthesis decline, all right, with the statins. Later on, after some days or a week or 2 weeks or so on, you will see more marked LDL receptor induction and a marked reduction in LDL because there are more LDL receptors to which LDL will bind. So it clears the plasma of LDL. Got it? So it's actually a phasic, so there's an initial response and then there is after the continuous use, there is a later or late response. So the initial response depends on synthesis, decline in synthesis, and of course the production of VLDL as a result. And the later response depends more on clearing of plasma from its LDL. But why liver needs cholesterol? Why needs LDL? We talked about it. Exactly. It has to produce bile all the time. So liver secretion as well as excretion is which one? What is the secretion and excretion of bile? This liver. That's bile. Yeah. It's the only medium it produces, and that's the secretion, of course. And whatever it has to excrete, it excretes also in the bile. So that becomes a secretion as well as excretion. Right? It's just like, you know, our kidneys. The kidneys filter something and then actively secrete something as well. You know? But those are not glands. Liver is a gland. Kidney is not a gland. That's why we don't say that, you know, we don't use that analogy for the kidney. But yes, for liver, yes. Alright. So statins, apart from reducing cholesterol, they can also reduce the oxidative stress. It can scavenge, it can help reduce the oxidative stress within the vascular epithelium and reduce the mild inflammation going on. Because atherosclerosis is an inflammatory disease of blood vessels. Right? It's a low level low level inflammation. And it's an inflammatory disease going on within blood vessels. And this leads to what? Recruitment of macrophages to scavenge it. Scavenge what? The lipids. which it fails, becomes foam cells. But because it fails, it doesn't keep quiet. Yeah, and it becomes a protracted battle rather than hit and clear and fast. No, it then becomes a protracted war, which is dragged over a period of time, and then becomes a low dose inflammation, which is going on and on and on and on. And because of that, what will happen? Because the macrophages will tend to digest it, tend to clear it enzymatically, they will produce inflammatory products, pro-inflammatory enzymes and so on, including metalloproteinases. Because this is the general schema of inflammation. You destroy and then you clear also. And this clearing and the clearing of the tissues and penetration of the tissues takes place with metalloproteinases. Now those metalloproteinases will try to digest the atheroma plaque to the point that it may rupture and release the lipid all of a sudden. Yeah? And what happens if the lipids are released from within the blood vessel?
Fibrosis?
Yeah, it actually functions as thromboplastin and starts the intrinsic pathway of prothrombin activator complex. Yeah, and then the intrinsic pathway kicks in. It stimulates Hegman factor, then 11, and then 9, and then 10, and so on. So, see, thrombosis takes place. Now, if it happens in a coronary blood vessel, coronary artery, the thrombosis will block it, leading to
Joint.
sudden ischemia and
Myocardial.
death of the area supplied, which is infarction. And that is called myocardial infarction or heart attack in common language. The same thing happens with the brain. So brain attack or stroke or cerebrovascular accident, CVA. So both are same. So this vulnerability of plaque to get ruptured means that remember, whenever there is some inflammation going on, there is some fibrosis also, because those same mediators which draw different scavengers, they also draw fibroblasts. Okay, because this healing with fibrosis. If healing back to the normal is not possible, then fibrosis takes the lead. Yeah, that's the normal tissue response. So what happens? That these statins, they help the fibroblasts to recruit more there and produce more fibrosis. So this fibrosis actually, I would say the atheromatous plaque is reinforced and prevents it from being ruptured. So people who have hypertension or who have diabetes and are at the risk of myocardial infarction as a result of atheroma rupture, we give them statins to control that and to prevent the rupture, even if their blood lipids are within normal range. So sometimes, I have seen a lot of people asking, why we should take this? My cholesterol is fine, it's within the normal, but the doctor prescribed this, I would say, statin. Why should I take it? Because we don't want to die of heart attack. Yeah, that's why. But this has to be told. Has to be told to the patient. Most of the physicians, they don't actually educate their patients. So they think these are lipid medications, and when they see it online in Google, they would also say, all right, this is for lowering lipid, but my lipids are normal. Yes, your lipids may be normal, but we don't want this. Okay? So that's why. But the difference is, for lipid lowering, these statins are given at a lower dose. Okay? Because that is the most effective function of statins. no doubt. For this particular function, we need to give them at a much higher dose. For example, if it's mastodon which is given 40 milligrams as a lipid lowering dose, we need 80 milligram, double the dose, for this. That's why those people who are there for the primary prevention or even secondary prevention of this thrombotic disease and thrombosis, you would see that doses are at a higher side. And please educate your patients, don't reduce the dose. And even the doctors need to be educated, don't reduce the dose, we need a higher dose for this function. If you reduce the dose, actually you are doing no benefit. You are not crossing the threshold for this function. You are trying to control the lipids which are already normal. So what is the big deal? I mean, you are actually burdening the system with no justification. Yes, please.
How there is a throat break, where is the cholesterol level is normal?
Sorry?
How is there is a thrombotic break?
Because
Where is there is cholesterol is normal?
yes, because this is absolutely possible, and we see lots and lots of patients with normal lipids and advanced atherosclerotic plaques and atherosclerotic heart disease, myocardial infarction, but normal lipids, because there are so many other ways. You see, this is atherosclerotic plaque is actually a response to inflammation, and endovascular inflammation can start by many things. For example, homocystinemia, if there is more homocysteine, vitamin B12 deficiency, folic acid deficiency, it leads to homocystinemia, and that is injurious. People who smoke, that is injurious to their endothelium. People who have susceptibility to suffer from metabolic stress or oxidative stress because of their genetic makeup, they can react to the environmental pollution. So environmental pollution, bacterial infections, homocystinemia, and the most important is cigarette smoking, tobacco smoking. That injures all parts of our body, including vascular endothelium.
Does that look at? So it's not maybe because cholesterol or lipid.
No. You see, that's what I'm saying. I was discussing once with a physician in a very large public sector cardiology setup, and I said, look, I have a hypothesis based on my previous research that it's not necessary that people should have high lipids for advanced cardiovascular disease. Do you see these cases? He said, yes. Around 20% of these, 25% of these are the ones which we keep on scratching our heads why they have it. So this is what it is. So some other day we will discuss it. Alright, so help reduce vascular inflammation and stabilize atherosclerotic plaque. And this function is just like, you need maybe 10 riyal for a burger, but if your father says, right, no, here is 5 riyal, just go and buy a burger. I said, come on, Baba, where can I no one will give me 5 riyal burger. I need 10. You are giving me sub-threshold. What I will be doing with these 5, I need a burger and a meal, and this is insufficient. So the same thing, if you are to prevent thrombosis, as I said, adequate doses is important. It shouldn't be sub-threshold. That's the key to understand. Alright? Clear? Now see, this is the reason we want you to be in the classroom. Because if you ask a question and he would listen, say for example, at the end he will learn. Now people, they think, all right, recording is good, that's fine, because during recording you are very, very cautious. That you don't say something which ultimately, backfires. See?
Yes.
So then recording is a double-edged sword. Yes, you get the content, but then you also miss a lot of lateral information which is essential. Got it? That's why. Being in the class, that's why it's important. And that's why you never see an online medical school. You'll always have an on-site medical school. There was the only instance was the COVID, and there was a temporary thing. Otherwise, have you ever heard of an online medical school? No. No.
I have one in Saudi Arabia.
Sorry?
I have one in Saudi Arabia.
Online?
Yeah.
And they see the patients online?
No, not medical.
And they...
Not medical, not medical.
Yes, that's what I'm saying.
Yeah.
So the medical school, I'm talking about the medical school. I mean, that's different than any other science.
Yeah.
We also have, back in our country, there's an open university. That means it's an online university. There's a virtual university. So there are many countries which have virtual education platforms. But for the medical college, never.
It's more, I think the literature, it has to be more active. It's better.
Good. So now let's see what are the examples. Common examples which we use, and there are many. There are many statins. All of them, they end with the statin. That's why the name is statins. This is their clan. This is their tribe. But simvastatin, atorvastatin, rosuvastatin, all of them. The ones with an asterisk are the ones which are prodrugs. That means they are metabolically activated after they are ingested. The liver activates them, and then they become functional. Okay? So, atorvastatin and rosuvastatin are nowadays very much prescribed as a statin. And the reason that that's commonly, the side effect profile is also good. And I'll show you what side effect profile we mean. And atorvastatin and rosuvastatin are much better tolerated than other statins, number one. Number two, their duration of action is long. You just need once daily dose, and that is sufficient. You don't need to take twice a day. Once a day is enough for most of the patients. Alright, so what are the adverse effects? Well, as I said, they are well tolerated generally, but by the way, just explain this also to your female colleagues. Side effects and adverse effects and toxic effects, these are different things. Side effects are just like innocent thing, you are taking a medication for something, but at the same time there is a parallel effect which you never designed, which you never wanted for that particular condition, but it is taking place, and that's fine. It's okay. Yeah, you went for the burger and you got fries also. Fine, that's okay. I mean, what else? So you buy one and you get one free. Yeah, so buy one, get one free, 1 plus 1. So that becomes a side effect. Adverse effect is something which is bad. It is also a side effect, but it's bad. That is called adverse effect. Yeah? We call atharat sayyi'a. Sayyi'a? Isn't it? Okay. And then we have toxic, which becomes life-threatening. Okay? What do you call it in Arabic? أثرات خطيرة للحياة. هذا؟ أيوة. So now picking up. Good. Okay, that's a positive. That's a positive feedback. All right. So they are generally well tolerated, but there are certain adverse effects which are problematic, and you may stop the medication if you see those items, these adverse effects. Number one is myopathy. Okay, so there is a muscle injury, drug-induced muscle injury, myopathy. And whenever there is muscle injury, you know that there is rise in the level of CK, creatine kinase. That's actually a marker of muscle injury, isn't it? Even for the heart, what is the marker for the heart injury? It's a muscle. There are 3 types of CK. CK MM, CKBB and CKMB. So which one is in the heart? CKMB. Which one is in the muscle? Muscle type, CKMM. And there is a brain type, BB. Yeah? So that's why. So CK here, the total CK or CKMM actually. But we don't say it's either CK total, and if you are interested to see this, whether it's from the heart or no, then CKMB. There are two tests available only. Yes.
CK
It's just like total cholesterol and LDL.
cell cancer.
Yeah.
Doctor, CK what stands for?
CK is creatine kinase.
Creatine kinase.
Yes.
Oh.
And that's an enzyme. Sorry?
For the brain, Doctor, which one?
BB. CKBB. But we don't measure it. We either measure total CK or for the heart CKMB. Alright, so these are enzymes actually, and these are intracellular enzymes. Just like liver enzymes, these are muscle enzymes. Okay? CK. Alright, so this can also reduce ubiquitin synthesis. Ubiquitin synthesis, are you familiar with ubiquitin? Coenzyme Q? Coenzyme Q, are you familiar with coenzyme Q? You see a lot of CoQ10, coenzyme Q10 capsules nowadays in Saudi Arabia. Now that's something, coming up already. All right. Are you familiar with the electron transport chain?
Yes.
Yes? Okay. Electron transport chain and oxidative phosphorylation. So do you recall there in oxidative phosphorylation, electron transport chain, there are 5 complexes. Complex 1, complex 2, complex 3, complex 4, and complex 5. Complex 5 is the last one where it's actually the ATP synthase taking place. Complex 1 is where NADH will enter the circle, Remember the reducing endurance?
Yeah.
Which are obtained from Krebs cycle, glycarboxylic acid cycle, and they enter another cycle they are just like a credit card. So you need to have hard cash, you need to go to the ATM, or the debit card. So NADH and FADH are just like debit cards. If you give it to a grocer, maybe you will be able to exchange them for some money, digitally, but if you need hard cash somewhere, of course you won't. If you want to give charity, you need to have hard cash, otherwise it's of no use, So not all countries have extensive digital monetization, but that's very wonderful here, honestly. A lot of digital and online, it's everything. Much better than many countries in the world, honestly. It's at par with the West here in Saudi Arabia. So myopathy, in UK we call it plastic money. The same going on here. I still remember once I had a hard time. I had cash, and now it was difficult for me to spend because no one was accepted. Here, at least you have cash. You can the shopkeeper will accept it. He will give you choice, cash or shabaka. Over there, if we offer them cash, they say no, shabaka only. Except, sorry about that. So I had to go to an outlet and get a traveler's, I would say, online card being printed against the cash deposited. So that was invested in North America. Anyhow, so reduced ubiquitin synthesis, the lower coenzyme Q. This is also one of the side effects and adverse effects. Then it also can lead to, because the drug is itself being metabolized in liver, it can lead to some rise in liver enzymes, some collateral damage to the liver. But maybe if it is one-fold rise in liver enzymes, that's why it's self-limited. Keep on consuming, keep on taking the drug, you advise the patient, all right, continue with the medication, and this trend will go down by itself. Okay? And it happens. But if there is a continuous rise from one fold, then it becomes two-fold, then it becomes three-fold, that means there is a subtle tissue damage, and then you need to stop. So myopathy, number one, and number two, liver injury. Yeah? Increase in liver enzymes by one fold, that's fine. Okay? But beyond that, you need to be careful. And probably, if it's a continuous trend of upward trend, then you probably need to stop the medication. So these are the two side effects which determine whether the statin therapy will continue or will stop. Okay? Alright, well, by the way, they are quite well tolerated well, and most of the times you don't find a need to stop. Alright, rarely, as I said, rarely there is hepatotoxicity. That means a continuous trend of upward levels of hepatic enzymes, liver enzymes. And sometimes it also leads to SLE, like autoimmune reactions. So again, in some individuals, not all. Alright, in pregnancy and lactation, this is contraindicated. So we don't prescribe these medications to pregnant ladies and ladies who are, mothers who are feeding their young ones.
Why is that?
Oh, because the children, they are not, you see, their liver toxicity is easy to happen.
Yeah.
That's why. So because of that, yeah, they are much more vulnerable as compared to an adult. Okay, temporary discontinuation. Sometimes you need to hold the statin. A patient who is taking statin, you advise them in few situations that, all right, hold it for some time, maybe a week or 10 days or 2 weeks, something like that. Right? Max, maybe a week, 10 days. Yeah. When, if there is a major illness means there is a burden on metabolic burden on the body. There is a lot of oxidative stress, and this may lead to liver injury, this may lead to muscle injury. Okay? So that's why. So once the illness is recovered, you continue. Then surgery or trauma. Because in surgery, again, that's the metabolic demand. It's oxidative stress. This is a stressful situation. Plus, there may be extensive tissue damage, yeah, leading to rise in CK. Trauma, whenever there is a trauma, external trauma, a road traffic accident, someone was involved in a brawl, in a fight, they punch each other and they hit each other and they have, muscular aches and pains, those individuals will have more chances of muscle injury, right? Because their CK is already high. There is already injury. So you are actually adding more to the injury, right? That's called adding injury to the insult. So that's why. So that's why in these situations you need to stop temporarily, and that's called holding the medication. Alright, we are done with the statins, the most important. Now let's move on to the next. Whatever we'll talk about is easier and it's less complicated, because statin is widely used and widely asked in your exams. We need to be more elaborate on it. Alright, so fatty acid. Now, once we are done with the cholesterol, let's focus on fatty acid. We know fatty acid is a fuel. Alright? And our liver, on daily basis, switches between these two states, well fed and fasted. Once we take a meal, around 3 to 4 hours after the meal, that time period is well fed state. After that, we gradually shift to fasting state. Right? In Ramadan, it's even more. Yeah? Because we are fasting from dawn to dusk. Okay? So So well-fed and fasting. Now, during well-fed state, the body consumes glucose. Recently, from the meal, a lot of glucose. Yeah? So more glucose-centered, carbohydrate-centered metabolism, glycolysis, and then menopause and so on. On the other hand, when fasting period starts, right? When after 3-4 hours post meal, the body starts shifting because the glucose levels, they are dwindling, they are going down. It's just like, say for example, I have say 100 riyal in my pocket, and I would fix, no, I won't consume all 100. I will consume 50, and I will stop spending once I reach. I won't spend 50 first of my riyal. I will keep it in my pocket. All right, but rather I will shift myself to credit card, something like that. Yeah. So the same way, body will have its critical threshold. When the glucose levels inside the liver go below a certain threshold, it stops the spending of glucose, but rather switches the energy from carbohydrate to fatty acid, lipid. And this is energy switching. So there is an energy switch, CMP and all these, and this is the switch which we talk about when we talk about metformin in diabetes, glitazones in diabetes, and fibrates in dyslipidemias. And this is how they are interrelated. All right.
So they work on regulate all lipid metabolism.
Sorry?
Fibrates work on the regulate all lipid metabolism.
Fatty acids.
Or fat acids.
Yeah. So when your patient has more triglycerides, more than 400, 500 milligram per deciliter, you may require adding fibrate. Before that, statin is enough. 400 to 500 milligram per deciliter triacylglycerol. Before reaching that point, the statins are good enough. So lifestyle modification, exercise, diet modification, and statin, good.
Both of them.
Once you cross 400 and 500, add it. Otherwise, hypertriglyceridemia will lead to what? What is the most dangerous consequence of hypertriglyceridemia? And this happens like this. Come on. What is the most dangerous consequence of hypertriglyceridemia? Acute pancreatitis. Never forget it. Acute pancreatitis. Yeah? And that is a life-threatening situation. Okay? All right. So, in this slide actually just wanted to show you that these nuclear factors, they have a crosstalk. Look, PPR alpha, and this is PPR gamma, which is primarily the influence of the prostanoids. And this one is a fatty acid. Those are prostanoids and the fatty acid. And ultimately, they converge on some areas of DNA where the expression of certain proteins will change. I said change. That means some of them will be increased in expression, others will be decreased in expression. So there's a crosstalk between energy level and this PPR system of nuclear factors. All right, so fibrates. These are ligands. Ligands means something which can bind to. And when we say here bind to, we actually mean bind to and activate. Otherwise, an inhibitor may also be a ligand in literal senses, but not what we mean. When we say something is a ligand, ligand means something which can bind to and activate. It's implicit in the meaning. Just like in the brackets, agonist, that's what I said. It's a ligand, but bracket, well, agonist, bind to and activate. of nuclear transcription factor, PPAR alpha, which along with another nuclear factor which is RXR or retinoid X receptors. Now retinoid X receptors are the ones which we commonly see involved in nuclear expression changes secondary to steroid hormones, prostaglandins, as well as the name, retinoid, vitamin A. Yep, that's why the name, retinoid. Alright, so stimulating PPAR alpha mediated pathway would cause following things. Number one, upregulation of lipoprotein lipase. Now, this means in tissues, in peripheral tissues, upregulation of lipoprotein lipase. That means now the tissues will try to digest the triglycerides and take up more fatty acids, clearing the plasma of triglycerides. That is why. That
In
is
the form of LDL.
sorry?
In the form of LDL.
No. Triglycerides. This is different. Triglycerides also are required. Triglycerides actually circulate in our body as cholesterol esters. Okay? So, in the form of VLDL also, yeah, you are right. There are fatty acids in the form of VLDL also. But here we mean triglyceride, triacylglycerol. Actually, it's a triglycerides and glycerol esters. Cholesterol esters. Alright, so this will clear the plasma of these triglycerides. That's why, I mean, when there is higher triglyceridemia and dangerous because of the risk of acute pancreatitis, we give it so that it clears the plasma and reduces the level. Yeah? And then, once you have started the consumption of something, you would also start its utilization metabolically, which is the beta oxidation. Remember, these fatty acids, they are metabolized in the chunks of 2 carbon units, yeah, as acetate. They become acetate molecules, so there are chunks of acetate molecules. You can see them as just like a brick, you know. It's actually, for example, if you have 50 bricks in the row, you can see, all right, there are 50 chunks. Yeah. So similarly, here we have, for example, if it is palmitic acid, 16 carbon fatty acid, it has 8 chunks, 8 units, which can be utilized as energy.
Acetate.
Yes, acetate. 8 pieces of acetate. And because it's always the second carbon which will be oxidized and released, yeah, that is the point where the splicing will take place. Yeah? So it's always the beta carbon because it's the second carbon. The first carbon is alpha. That's why you will always remember why is beta oxidation? Because it's the second carbon all the time. Yeah? So they remove the first 2, and then whatever remains, they remove another first 2, another first 2, another first 2. Yeah? So whatever remains, from the first 2. So the second carbon is that's what beta oxidation. Alright, so thus reduced triacylglycerol leads to reduced VLDL production. Because VLDL requires more triglycerides. That's why we call it VLDL. So less triglycerides, less VLDL. Less VLDL, less total cholesterol, and less LDL. Because less IDL and less LDL. What are the adverse effects? Something which is really inconspicuous, like nausea and rash and so on. And sometimes, because they are nuclear factors, they can reduce the differentiation of the hematopoietic progenitor cells. And then, again, myopathy. Especially if given together with statins. So that's why we don't most of the times combine. Statins are enough to take care of all types of lipids. Okay? Especially when we advise the patient for lifestyle modification, dietary modification, and then statin. then there is no solution for all types of issues. But sometimes, because of the very high triglyceridemia, we may want to edit, but then remove as soon as you achieve the target, and then myopathy, otherwise myopathy is a problem. All right, what else? Because cholesterol in the body, the free cholesterol is not free, is actually as an ester with fatty acid. Cholesterol is alkaline, fatty acid is acidic. So in the body they don't, they marry and they go together as a pair. Yeah. So because of this, because you have killed so much acid, the cholesterol, there are more cholesterol now. So what will happen to them? They will be excreted virgin. They will be virgin and they will go excreted in where? In the bile. And within there, where? In the gallbladder. And they will remain there and precipitate into sludge and then may form pellets. We call them gallstones. Okay? So that increases the risk of gallstones. So long-term therapy with fibrates may lead to a risk of gallstones. Okay? And then of course, there are some risks of hepatotoxicity and as well as nephrotoxicity. Remember, these are drugs which have sometimes oxidative stress within the cell involved. And look at that, kidney and liver, they are the sites of more oxidoreductases. The actions taking place. That's why. These are the tissues which succumb first, which face the head on the oxidative stress first. Alright. Third one, niacin. It's B3, vitamin B3, niacin. We need niacin as a precursor of many cofactors in our energy metabolism. For example, NAD. We need nicotinamide, niacin, adenine dinucleotide. Yeah. Then we have NADP also requires it. So we need it as a vitamin daily around 20 milligrams. But for the dyslipidemia treatment, we needed 100 times more dose. That is 2,000 milligrams, 2 grams, 2,000 milligrams. Now that's a very high dose, okay? And not achieved through dietary modification. That's why sometimes when we need to supplement it, we need to give it. And why it's important to give it? Because ultimately its beneficial effect is more on HDL as compared to LDL. And how does it, what are the effects? Number one, it releases triglycerols and fatty acids from adipose tissue, mobilize them. Alright? Mobilization is reduced actually. And then it also induces the clearance of VLDL, okay, through lipoprotein lipase, because VLDL has more fatty acids. So, when VLDL is cleared of lipids and so on, okay, and then hepatic synthesis of LDL and VLDL will go down, and HDL synthesis will go up. And the most, if you see percentage-wise, the most dramatic rise in HDL is seen with niacin. I'll show you a chart, and you will realize how it is. What are the adverse effects? GI upset, because we take it orally. Skin flushing. Okay? So this is something which we keep on asking in your exams. Skin flushing. Hepatotoxicity, most of the time we don't ask, honestly, because there are many drugs which cause hepatotoxicity. This is the third drug of the group, and this is also causing some degree of hepatotoxicity, potentially. Now, another, the important thing is glucose intolerance. If you give niacinamide to someone, their blood glucose control may go erratic. And remember, many of these dyslipidemic patients, they are diabetics also. Yeah, and the thing you would want the least to happen is glucose intolerance in diabetics. So that's why most of the times we don't prefer to give niacin, although it's useful, right? But most of the times we don't use it. We control this with dietary modification, dietary modification means low carbohydrate, low fats, more water, more fruits, vegetables, and so on. Lifestyle modification is part of lifestyle modification.
Why are we scared?
And then, sorry?
Why are we scared of glucose intolerance in patients with diabetes? Isn't it something depressive?
Sorry?
Why are we scared of glucose intolerance?
A diabetic person. Otherwise, either you need to increase the dose of insulin, or you increase the dose of other medication if he's on like. See, this happens most of the times in people who are obese, type 2 diabetes. And many type 2 diabetes patients do not get insulin. They are treated on oral drugs. Yeah? So oral drugs have got an upper limit. You can't control beyond. So either you need to add insulin, and insulin addition has got its own issues and so many things. So you don't want to disrupt the balance, and this balance is best avoided. This imbalance is best avoided if you advise your patient. All right, do some exercise. Some means some strenuous exercise where that's called it's not just pleasant walk, it's brisk walk. Yeah, and then dietary modification. Stress should be reduced. Sleep should be adequate. The meal time should be constant. And then you add statin to get the goals, and that's achievable in vast majority of the patients. You don't need to do this. All right? But sometimes, yes, we need if the people are not, responding well, you need to add this also. Especially there is one type of familial dyslipidemia where you may require this, adding this. All right, bile acid binding resins, we already talked about. They scavenge and they induce the excretion of bile acids, thereby shifting the focus of liver from making LDL to bile acid. So it diverts the cholesterol from VLDL synthesis to bile acid synthesis, because that is an emergency. Yeah, so nothing actually. And here is ezetimibe. Ezetimibe is a newer agent among the lot, and this actually also helps lose the intestinal. It promotes the intestinal loss of steroids, which are sometimes used as the raw material to synthesize cholesterol. All right, so it inhibits the intestinal epithelial protein, which is essential for absorption of steroids. Yeah, NPC 1L1. And these are the latest addition to the list, but their roles are limited, and they are limited to those cases which are familial dyslipidemias, difficult to treat, resistant to statins, fibrates, and all these drugs. These are costly medications available in US under, of course, on prescription, of course. To the best of my knowledge, not available here in Saudi Arabia and most parts of the world. We don't have them. All right. So these are monoclonal antibodies, and anilokumab, for example, that is the prototype of this. It actually against a protein which when this one binds to that protein, the death of receptor yeah, the receptor becomes immortal. Yeah, so the receptor, all the receptors in our body, all of the receptors have a half-life. Yeah, they have a lifetime. They are produced, they are transported and to their target part of the cell, and then over time they are removed. It's a dynamic process. Yeah, so they are synthesized and removed, synthesized and recycled and removed, something like that. So we can disrupt that and allow more LDL receptor half-life, yeah, by blocking the scavenging or removal of this particular receptor by giving the monoclonal antibody of this type. All right, then we have certain other, I would say, drugs which inhibit the transfer of certain proteins required for metabolism of lipoproteins. If I summarize it up in more simpler words, okay? And these are newer drugs, not very much in use, but they are reserved for very special cases, and you can see which ones. Yeah, just the reputation, and here it is. Look at that. This is the Fredrickson and WHO classification of hyperlipoproteinemia. There are 6 varieties which are named 1, 2A and 2B, so that makes 2, yeah? And then 3, 4 and 5. So 1, 2, 3, 4, 5, but because 2 has got 2 subtypes, so the total becomes 6. And you can see there are certain lipoproteins which get elevated in these conditions. Okay? Most of the dyslipidemias, familial dyslipidemia usually is 2B or 2A. So that's why this is treatable with HMG-CoA reductase inhibitor. That means a statin. Okay? But we sometimes need, sometimes we see all these other subtypes, and here we can try those rare drugs. Look, for example, here. Look, for example, here. Sometimes they are difficult to treat, then we can probably use all this. Otherwise, look at the moderate rise, and this is responsive to the conventional therapy. All right, now here is something we keep on asking you in MCQs. The percent gain in HDL or LDL reduction. So percent loss in LDL and percent gain in HDL. Okay? So which of these drugs listed, we have just talked about, has the most beneficial effect on HDL?
Nice.
All right? So it's almost 35%. Very drastic. On the other hand, statins up to 15% has been reported with the modern atorvastatin and rosuvastatin up to 15%. So almost half of it, which is good enough, honestly. I mean, exercise increases HDL. With the statin, you will have another rise in HDL. So it should come back to the normal range. And again, I mean, absolute value is important, yes, but it's the ratio which is much more important. All right? So as a ratio, if it is within the normal range, it's fine. You don't need to worry about it. And we don't have any evidence to worry about, honestly. All right, so there is a reduction. Look at that. Which one has the best reduction in LDL?
The second is the first one.
And that is the main problem. So that's why all dyslipidemia's main problem is actually LDL. Yeah, that's why statin is the main drug here. And whenever, sorry?
So when drug of choice in LDL?
In almost all types, We can start with this And look at the diaphragm. Look, this is a fibrate. Triglycerides. When triglycerides are involved, this is something which is of use. But with the new statins, look, it's almost comparable. Okay? So that's why no wonder atorvastatin and rosuvastatin are really useful in modest rise in HDL, good decline in triglycerides, and really good control over LDL. That's why they are drug of choice in many and majority of the cases. We will start from this. Plus, it has additional advantages. Fibrosis of the atheromatous plaque, prevention of thrombosis, isn't it? Reduction in the inflammatory situation in the endothelial inflammation, isn't it? So all those are beneficial effects of statins we don't see in others. So that's why, again, everything favors more statin use, that's why. Okay? Thank you very much, and hope you understood what we talked about. Thank you.
Thank you.
My pleasure. If you have any questions,
With those statins, we said we use them in cases of myocardial infarction. Can we use them?
say it again.
Statins, we said that we use them in cases of myocardial infarction. Can we use them in cerebral infarction?
Yes. Cerebral infarction, see, look, we are targeting what? We are targeting the atheromatous plaque. Where?
Anyway,
Anywhere in the body. It may be in the coronaries, it may be in the carotids.
it causes neuropathy. That's why
No, but see, look, carotids. See, the cerebral infarct usually is secondary to atherosclerosis of the internal carotid artery. Yeah? And remember, arterial circulation is a high pressure zone. And high pressure and fluctuation of the pressure. And that has got a physical effect on the dissolution as well. So apart from weakening, you have a weak wall and there is I would say, gush of water. There is a sudden, sorry? Rupture, yeah. So there will be a sudden rise in the pressure and natural forces leading to rupture, an easy rupture. It's already vulnerable. And with atherosclerotic disease and ongoing inflammation, it becomes even more. So what you want to reduce the vulnerability of thrombosis. Yeah? And this is achieved by high dose statin therapy.
because I saw that it may cause neuropathy, and I thought maybe not use them.
True, it is possible. It is possible, but it's just like, say for example, paracetamol.
Yeah.
Paracetamol, we know, can lead to rise in liver enzymes. But which one is important? Saving the high fever or worrying about the enzymes? Exactly, because that will kill within hours. Yeah? And the liver enzyme has a latency, number one. Number two, there is a good reserve. Before that, it becomes really problematic.
Well related side effects.
Yeah. It's just like, when we swim, we hold the breath. So we deprive our body of oxygen. So here, would you like to breathe in? Which one is important? Holding the breath is important, because otherwise we'll drown. And we'll drown like this. Yeah? So it's the same logic. Sometimes you need to prioritize which of these effects are tolerable and to what extent. Yeah? Sometimes you say, all right, I will catch hold of it. Let's address this immediate issue first. Yeah? Any questions?
Thank you.
Thank you.
My pleasure.